So let's talk about benzodiazepine battles. So benzodiazepines are a class of drugs that tends to involve strong emotions. They kill people. If you've lost a loved one from a benzodiazepine, that's a very intense thing. If you're a patient who suffers with an anxiety disorder or panic, you tend to be kind of attached to the thing that gives you relief. There's drugs that have strong emotions around them. And I'm not touching on, by the way, the Z drugs, which is a whole nother talk, but some of the data about benzodiazepines can also be prescribed to the Z drugs, the sleepers with the Z in them. So, and again, benzodiazepines cut both ways, both very powerful and also relatively low safety index in terms of overdose. So this dog says, for some, the answer is a cat. For most, the answer is a dog. Some practices approach the benzodiazepine challenge by just saying, I don't prescribe benzodiazepines. There are psychiatrists that take that stance. I work as an evaluator for PACE, and some physicians have chosen to take that stance. You can actually get along in clinical practice and not prescribe benzodiazepines. There's a number of other drugs for anxiety disorders, and you can just not deal with them. That's kind of the cat response. Many of us choose the dog response, which is, we prescribe them, but we're aware of the risks, and we kind of sit in this difficult clinical spot and try to use our judgment. On the left is the pharmacologic actions of the benzodiazepines. These are very helpful for convulsions, as central muscle relaxants, for their amnestic benefits, and for anxiolysis and anti-aggressive benefits. When I was attending in the UCSD psychiatric emergency room, lorazepam was a trusted friend. So those are the benefits you see for epilepsy, alcohol withdrawal, in the middle column, spasticity and tension. Colonoscopy is enhanced significantly by the amnestic effect of midazolam and then agitation reduction. But then the downside on the right-hand column is that the anticonvulsive benefits mean that you have withdrawal seizures. The central muscle relaxant benefits mean you have ataxia, falls, and respiratory depression. You can have blackouts from benzodiazepines. If you mix them with alcohol, you can have a blackout. And then also patients who take higher amounts may have indifference or feel checked out. So just here's another layout of the pros and cons of benzodiazepines, just to review them again, because again, if you're in the camp as someone who prescribes benzos, you're really sitting on both of the benefits. So on the left-hand side, benzodiazepines, based on the research, are unquestionably effective, both on the short term, as needed. SSRIs don't work as needed, and on the long term. There's multiple routes. That's if you work in emergency departments, that's nice. They're very inexpensive. And then they have a different side effect profile than the SSRIs. Some people just can't tolerate SSRIs. And so for those patients, it's nice. And then on the right-hand side, again, we're going to walk through these very quickly together. Addiction, sedation, and falls. They impair cognition. And there was a question about dementia. We'll talk about, obviously, diversion and death are a risk of benzodiazepines. And then this term that I want you to lock down, I'm going to try to mention it 3 times because I think it's a nice take-home, which is benzodiazepines taken as prescribed induce medical tolerance. Remember, I said I was going to give you a term. Medical tolerance is the term for when a patient takes a medicine as prescribed and develops a physiologic tolerance to the drug. Rather than calling them dependent, which has a lot of baggage, I say they've developed medical tolerance, which necessitates a supervised withdrawal. And then benzodiazepines have withdrawal, as do a lot of our drugs. This is an artist named Lil Peep. I think I said it right. I don't know much about his music, but I do know that he is a 5th-generation victim of chill pills and an overdose. So again, medicines for anxiety and sleep have been taking out young people for a long time. Let's talk about benzodiazepines and addiction. In brief, benzodiazepines have an addiction risk, like alcohol, like nicotine. They're an addiction risk. Not everyone exposed to alcohol develops alcohol addiction. Some percentage do. Benzodiazepines, like alcohol, like cocaine, cause dopamine release in the nucleus accumbens, which means that they can be addictive in high-risk people. So you see the yellow benzodiazepine binding to the GABA and the dopamine receptor. That causes increase in dopamine in the nucleus accumbens, and the brain says this is a good thing, and the brain remembers it, and the brain likes it, especially in at-risk individuals. Interestingly, if you dive into the addiction literature in animals, benzodiazepines aren't quite as reinforcing as things like opiates or even stimulants, but they are more reinforcing than things like aspirin. Who's at risk of benzodiazepine abuse? This is kind of intuitive. If you have a history of a substance use disorder, history of an alcohol use disorder, personality disorders, ASPD is antisocial personality, borderline personality. If you have a family history of alcohol or substance use disorders, you may have the brain wiring that will cause increased addiction risk. And then also a history of impulsivity. These are high-risk patients. One take home when looking at the literature on benzodiazepines is that benzodiazepines are often part of a combo that leads to a bad outcome, alcohol or opiates. That's how they get you. They're not often primary. So this is the unholy triad of prescription drugs, benzos, stimulants, and opiates that make us all scratch our heads. So drug-related deaths. In 2011, this is a little bit old data, but it holds. I think it still holds true. Drug and alcohol was about benzos were involved in about a fifth of ED visits. Deaths attributed to benzos increased 5 times in the period from 1999 to 2009. So again, increase in death rates from benzodiazepines. And alprazolam is kind of the worst actor in this. These statistics. You can see it pictorially here. These are ED visits involving non-medical use of prescription drugs. So in yellow, the total visits. The blue is the benzodiazepines, about a third of total visits for non-medical use of prescription drugs. And then you see alprazolam is a good third of the benzo. So alprazolam is a drug you may want to tuck away in a special part of your brain that's a specially street desired drug. This is the most recent statistics I could find, 2018. You see the lowest line here is overdose death from benzodiazepines alone, without any opiates. But then the yellow and green are benzos plus synthetic opiates, fentanyl, and then benzos and any opiate. So benzos combined with something else is where you get the big jump. Here is drug overdose death up through 2018. Again, synthetic opiates is yellow. That's your fentanyls. You see prescription opiates are starting to head down. That's the light blue. Good education. And then you can see here the benzodiazepines is that kind of ugly olive-colored line. Not one of the top drugs necessarily, but it's the combination. Benzodiazepines, as you warn your patients, are bad for driving. There's a significant risk of motor vehicle accidents. No surprise, that's another one of the risks, especially for new starts. The research on patients on chronic benzodiazepines is a little mixed, but it's likely that a patient on a stable list of chronic benzodiazepines doesn't have increased MVA risk. Obviously, benzos are linked with injuries and falls, and so that statistic where there's an increased frequency in older patients is problematic. Any sedatives, hypnotics, antidepressants, and benzos can cause an increase in falls in the elderly. There was a question in 2014. This research report got a lot of press because it said that benzodiazepine use was associated with an increased risk of Alzheimer's. Made the lay press. Patients would come in, ask about it. We were scratching our heads for a while. The best, most recent data. This is 2020. Large cohort of patients from the Danish National Patient Registry, no association between benzos, Z drugs, and dementia, and there was some evidence of a protective effect. So again, the highest level science, I tell patients, is not just double-blind, placebo-controlled, blah, 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 but then also replicated. And so this finding about dementia was not replicated. We may be able to rest relatively well. This is a well-done study, relatively well-assured. But research indicates that there's moderate to large deficits when you study the cognition in long-term benzo users. So it's possible that use of benzodiazepines does impair cognition in some other ways that are unclear. So remember I told you this word. So aside from addiction and aside from overdose and aside from death and aside from falls, benzodiazepines taken as prescribed induce a condition I'm encouraging you to call medical tolerance. We own some of it because we prescribe the drug. So the patient's medically tolerant. It's not shaming, it's not dependence, it's not, it gets you out of that quagmire. So I define this as a state of physiological tolerance induced by persistent exposure to certain classes of prescribed drugs. If you're medically tolerant, that means you're going to have withdrawal when you stop. And if you think about it, this medical tolerance is induced by benzos, opiates, clonidine, SSRIs and SNRIs. If you stop Effexor, you're going to have withdrawal. But not hydrochlorothiazide or statins. So I just like the term medical tolerance as a non-shaming way to talk about this condition. We got to have realistic expectations if we're asking patients to stop benzos. So let's talk a little bit about benzo withdrawal. A patient on a moderate dose of benzodiazepines, or even a small dose, can be very sensitive. I don't know why my slide is doing that. I apologize. Can become very sensitive to withdrawals, and so we're going to talk about how to manage the withdrawals when the patient's medically tolerant. They've been dutifully taking the medicine you or your colleague prescribed for a long time. You want to get them off, but it can be tricky for them. Here's the actual numbers of benzodiazepine withdrawal. Insomnia is extremely common on the left, 71%. Mood swings, myalgia can be a very difficult affair to withdraw from benzodiazepines. And again, this is not addiction, this is medical tolerance. There are some medicines that, as an addiction specialist, for example, I'll use to help. In the past, they use carbamazepine and valproate. Some people use phenobarbital or barbiturates if somebody comes in and they're eating, 4 Xannies bars a day, and we need to taper them off over 30 days or so. Some people use phenobarbital. The medicine I'm going to encourage you to maybe experiment with a little bit more if you're not already comfortable with it is pregabalin. I find it very useful. I think it's got some advantages over gabapentin. There are some reports of abuse and misuse, mostly in addiction populations, but I find it to be a really helpful drug, and the literature that it's helpful for generalized anxiety is quite compelling. If any of you want the research supporting that, you can email me, because I think it's a really helpful medicine. So this is an interesting study. I just want to dive into a little bit. This addresses the issue of withdrawal from patients who are medically tolerant. So the American Board of Internal Medicine recommended against use of benzos for adults 65 and older because of all the fall data and cognition data. And so they instituted this in this study from 2014, a deprescribing intervention. Just gave the patient some information in this certain practice. 1,200 participants. 86 completed the study. 62% in response to the intervention had a conversation with stopping the benzo with their physician or pharmacist. And about 1/3 discontinued benzodiazepines. So that's a lot, probably spared significant side effects. 5% of the control group did. So people aren't going to stop benzos on their own. And what was interesting is the factors that didn't influence benzodiazepine discontinuation. So older patients, sex, how long the patient had been on it, previous attempts to taper. None of those in the research determined whether the patient was actually successful. So the point is, many patients will benefit from psychoeducation and a slow benzodiazepine taper.